That's a little bit better. Okay. All right. Welcome everyone to another installment of CPC. So I'm your host today, David Lambert. Good to see everyone. I'm going to move on to a little bit about the history, and we just first want to start by welcoming all of our applicants as well. So CPC is a case we've been doing here for some time now. It's something we do every Friday during the school year, during the traditional academic year. And it's something that actually started originally at Harvard, and it was born out of the idea of analyzing legal cases and putting people kind of on the spot and going through medical cases. So the way it works is we learn from a master clinician going through and thinking through an interesting and challenging case. And so it was brought here to WashU a while ago by Dr. George Dock. A little bit more about Dr. Dow. So here is the information on where he's been before: University of Akron for undergraduate, and then went to medical school at Northeast Ohio Medical University prior to joining us for residency. And we've been so fortunate to have him on as faculty and as a wonderful APD, and I know serves as just an awesome mentor and colleague and friend to so many of us, including the chiefs. So we have a case of a 68-year-old female with no significant past medical history who came to the hospital with fevers and dark urine. And so we start and want to get your initial thoughts on that presentation.
Yep. So when I think about this case, the first thing that I think of is the dark urine. And I've split here kind of the three things that I think about: dehydration, which is the most common, things being common, and then the other two things that we can look at in the urine, which is bilirubin and blood. And so when I think about bilirubin, I think about conjugated, unconjugated, so conjugated stuff, liver stuff. And so some of the first things I'll think about when we're thinking about the history is, with this no past medical history, we can ask more, pointed questions towards, why would this person have cirrhosis? Maybe this is jaundice. And so asking those questions about alcohol, about hepatitis C, and other kind of cirrhosis symptoms or portal hypertension syndromes of lower extremity edema, or if they've had melena. And so we'll put the unconjugated on the side, and then thinking about the other thing, thinking about blood, thinking about any of the things that cause blood to come out. So you have glomerular problems and then non-glomerular problems. And so if you think about the glomerular things, thinking about glomerulonephritis, and then also thinking about the mimics, which would be hemoglobinuria and myoglobinuria. And so going back to the bilirubin, thinking about whether or not this is some sort of hemolytic anemia, and whether or not that's causing your urine to be dark. And then the myoglobinuria, really thinking about whether or not this is a muscle process. So that's kind of where I would start. And then, when we're asking more questions for, the history, if we're thinking of like an anemia, really thinking about, does this person have shortness of breath, fatigue, or general malaise kind of symptoms, where you're not going to get something super specific. And then kind of thinking about, hey, what precipitated this? Will probably be this fever. Fevers, as we know, are not super specific. And so when we're thinking about it, right, these are kind of our big buckets: infection, inflammation of some sort of autoimmune or something like that, or cancer. And so kind of going through the case, really thinking about, what is in the urine first. I think I'm just as interested in what that is, and that will actually help, guide a lot of the history questions. And then that will also help dictate all of our next laboratory tests.
Yeah, thank you. And I think you touched on such a great point about the one-liner in particular. When a patient's coming in and saying they have dark urine, we don't quite yet know what that means. And so it keeps your differential so much more broad. So getting into a little bit about the HPI. So this is a patient who 6 days prior to coming to the hospital started having more daily fevers, noted a Tmax at home of 105 or 101 Fahrenheit. Over the last week has been intermittently taking ibuprofen to try and help with the fevers. And 2 to 3 days prior to coming to the hospital had darker urine and decreased urine output. Also noted right greater than left-sided back or flank pain, but isn't so sure if this is significantly worse from the typical back pain that she experiences most days. She did go to urgent care and then wasn't very satisfied with the answer or workup that she received there, and then decided to present to the ED. A couple more pertinent details: past medical history. So she does have a history of celiac disease and a questionable history of Sjogren's. But other than that, has been relatively healthy and not really been needing to follow with physicians. She's had these two more common procedures and doesn't really take a significant amount of medications. And you can see the family history there. As far as review of systems, so again, endorses fevers and fatigue, as well as myalgias and a decreased appetite. has a long-standing burning in the mouth. And again, just to give you a little bit more about that history of Sjogren's, it was at one point thought that she may have Sjogren's, had received a biopsy. The biopsy was negative, and then was sort of lost to follow-up, and again, had not been following with providers. Other pertinent positives, decreased urine output and dark urine that was described as having a red tinge. And then again, the back and flank pain. So any additional thoughts? And I'm happy to go back to either of those slides.
Yeah, you can start back at the beginning.
Megan, which one did you want to see?
Oh, so sorry, from the history.
Yeah.
So one of the things that stands out is that this is kind of like a very acute presentation. So I'm assuming prior to 6 days ago, she was completely normal, not having any symptoms. And so this kind of tells us, hey, something acute is happening that has precipitated something. When she was having that fever of 101, she wasn't really having any specific symptoms, no dysuria, no pulmonary things. She was just and then were these daily fevers, or are they kind of like all day fevers, or were they kind of like coming at nighttime?
They were described as daily, and she was taking the ibuprofen pretty much throughout the day to try to keep them. It was never much higher than 101.
Okay, and then the other thing when we have these patients who are having these fevers and they take ibuprofen, one of the things too is that can also cause like the constrictions in the kidneys, and that can worsen the renal function. So was her PO intake okay, or was she having less PO intake?
The PO intake has been okay. Has not felt great because of the fevers, but again, no localizing symptoms.
And then any travel history that we should be aware of?
Nope.
Okay, and then any sick contacts?
No.
Okay. And then here, what's interesting is this Sjogren's. So, this questionable autoimmune history that people get. And then sometimes like they've had these things for a long time, and like, they sometimes just get inappropriately diagnosed. And so, in the past, has she ever had, so she's had these Sjogren's syndromes for how long?
It was like 5 years at this point.
5 years. And then did she have any other, signs of rheumatologic diseases, any joint pains, any rashes that she's noted?
Yeah, that's a good question. No.
Okay. And then does she see a PCP regularly where we have some baselines?
No.
No.
No, the last set of labs actually prior to this admission was like 3 or 4 years prior, which obviously is a pretty long time given her age.
Okay. And then during those 5 years, what kind of predominant symptoms was she having? Just dry eyes, dry mouth?
So it was only the dry mouth.
Only dry mouth.
Only dry mouth. Did not ever complain of dry eyes.
Okay. Not sure what to make of the family history other than her sister might have some autoimmune disease too. And then, yeah, I'm not sure what more to make. And then for the review systems, and then myalgias. Where are these myalgias?
Diffuse.
Diffuse myalgias. Okay. And so one of the things that you think of for red tinged would be like myoglobin. So if she has something like rhabdo. And so also kind of wondering if, with these fevers, if she had like a viral illness that kind of disposed you to that. And then there's no change in the long-standing burning in the mouth. One of the reasons why I think that is if this has been going on for a long time, either that's related or it's just kind of there. And then for the decreased urine output, really going to be looking at the renal function when we get to the next spots. As far as the flank pain, right, things that I kind of think of is, the kidneys are right there. And so wondering if she also has a urinary tract infection or pyelo, which would be a pretty obvious cause of, fevers and back pain. And then the other kind of things that I would think of is, is there inflammation there? Is the kidney swollen? For other reasons. So yeah, let's go.
Do you feel like from the history that we've gotten and from this review of systems, you've sort of, I hear you moving a little bit more towards the kidney, and we had initially talked a little bit about liver processes. Have we sort of moved away from that just based on this history?
Yeah, I think looking at it, she's not really having a lot of nausea, no abdominal fullness. We're not getting any swelling kind of symptoms. So yeah, and she's not describing any jaundice. Right. So,
and no alcohol, no other risk factors for liver disease that we're aware of. So moving into our physical exam on presentation, mildly hypertensive to 149/82. Otherwise, vitals were relatively unremarkable. Not quite febrile, but slightly elevated temperature at 100. Affect was described as anxious, but other than that, very normal physical exam. And so if you're ready, we can move into diagnostics.
Yeah, so I think what will be most helpful would be a urinalysis first, if that's the abnormality, and then a CBC, thinking, going back to our original differential, kind of looking at the CBC, the BNP, and the LFTs. We can still look at the bilirubin. And then we also obviously want to look at the creatinine and see what that's doing and see if there's any other, metabolic derangements from the kidney. And then specifically looking at the UA, looking to see if there are on the dipstick, if there's 4+ blood or elevated blood, and then looking at the microscopic if there's actually blood there. If there's actually blood there, then that tells us, hey, there's an actual hematuria process. And if not, we're looking for something else.
Do you want to start with the initial labs or the urine studies?
Let's do urine.
Yeah.
Okay, so what we're seeing is we have 2+ protein, 3+ blood. Sorry, I'm just reading this to you. RBCs and the RBC CAS presence. And then, so this tells us that there's true hematuria. With the CAS being present, what we're really thinking about is like a glomerular process. So I think that's, correct me if I'm wrong, but more specific for like something coming from the glomerulus. And so one of the things I'd be worried about is whether or not this is glomerular nephritis going on. And so I also want to kind of go back to our BMP and try to see, what we're seeing.
Yeah, and lastly, I also wanted to ask you about here too. What do you make as far as the proteinuria and kind of the discrepancy? Can you comment on the discrepancy between the ratio that we obtain in that one-time value versus the 24-hour urine protein?
Sure. Well, one thing we're going to have to see what the creatinine is. Oftentimes during an acute kidney injury, it won't be like, if there's an acute kidney injury, it won't really tell you much. It's going to tell you what happened during that day, during that patient's injury.
Yeah.
And then also for the protein, I think it has to do a lot with concentrations. And then that's why we confirm it with the actual 24. So it may just be like influx.
Yeah. So we'll start with the chem panel.
Okay, so the creatinine is elevated. And then our sodium is 129 and our chloride is 90. And so we can do our simple hyponatremic workup. And then our LFTs look normal. There's no elevated bilirubin, so we're not worried about that. And so there's, a significant creatinine elevation. And then looking at the other electrolytes or potassium or bicarb, it doesn't look like anything is crazy out of whack. The white blood cell being elevated, hard to know if this is just acute inflammation. Right now, obviously, there's a fever. And so I think it is reasonable to go ahead and think about whether or not this patient has sepsis. If you guys are ever wondering if this patient might have sepsis and the patient's febrile, it's always okay to give a dose of antibiotics, right? And then we can have a couple days to kind of figure out what to do next. The hemoglobin is 11.2 and we don't have a baseline. So I wonder if this is just acute or if this is chronic, right? So I'm not quite sure to make of it, but it's not super low. And then the absolute neutrophil count is elevated, so it's neutrophilic.
Yeah. So this is the last hemoglobin we have. I mean, the one prior to this was 5 or 6 years ago, and it was normal. It was in the 12 to 13 range. What do you make now with this kidney injury moving towards both management? I know you talked about infectious and doing a sepsis workup, but how, in light of the information we have from the chem panel and the UA, are you kind of adjusting your management strategy and or further workup?
Yeah, so as I think about this, what's interesting is that, usually when people have like an acute fever and they kind of get sick, right? They do start to eat less. And the first thing I think of is like common things being common. When people are dehydrated, they eat less, right? And they drink less. And so I wonder which component of this is a prerenal portion. So I would give them some fluid if they don't look like if they're still making urine. I would try to at least get them to a point where they are, euvolemic, right? And then kind of see where the creatinine lays out. We know that this is quite a big elevation. And so if we're thinking of a glomerular nephritis, especially with the urinalysis, we would be thinking of that differential, right? And so in that differential, it's always a long list and you always have to look it up every single time. I am not a nephrologist, and so I always have to think about it. But the things that come to mind are going to be immune-mediated, so complement-mediated, or immune complex-mediated, so post-infections, or like the cryoglobulinemia thing. And then the other kind of things for immune stuff would be antibody-mediated, so like IgAs. And then also kind of next to it is going to be like the vascular aspects. So vasculitides, like a vasculitis.
Yeah.
So like ANCA vasculitis or like Yeah, so like ANCA, or you can think of like the basement membrane thing. And so those would kind of usually think of the other systems, right? So is there respiratory involvement? Is there nasal involvement, right? So if there's, they're talking about the mouth, usually we think about, Wegener's or the granulomatous one to really be like NERS, right? But like more respiratory. But that's something to consider too. So as we kind of go with those next steps, that's what I would send out next, which should be like the C3, the C4, the ANA, the ANCA, C3, C4 data series.
Yeah. So more of a rheumatologic workup.
And then lupus, I guess. Yeah.
Now, where would you like to go next? Did you want to do any imaging at this point?
Yeah, so oftentimes in our little workup of pre, post, and like intrarenal for the AKIs, we always look at the kidneys. And so we're going to get a nephrology consult, and it's always kind of good to just make sure that the kidneys look okay. I'm not sure if that's where I put the bang for my buck, but we could get it.
Yeah, it's low, low cost, right? Ultrasounds and the imaging. So I'll provide you the imaging that was obtained.
So with the mild stranding of both kidneys, there is inflammation. And so actually I would treat this, kind of acutely with antibiotics. If she's never really seen antibiotics in the last couple months, I think it'd be reasonable to just start with ceftriaxone, call it a day. She has an allergy to Augmentin, so we have to ask what that allergy is. Bilateral patent renal arteries. So basically there's just no obstruction there. Yeah, and so thinking about that stranding of the kidneys, kind of thinking like, what else causes that stranding? Really, I'm really thinking of just like an acute infection or like pyelo or something.
And so what are you sending off next at this point, knowing what we know about what the kidney function looks like and the hematuria?
Yeah. So I think it would be those rheumatological labs. The other things that you could do if you're like also kind of working up, the shotgun approach with like the nephrotic syndromes is you could do all the things that are associated with them. Like the HIB, HBV, HCV, HIV, those kind of things. Okay, and so we see that this patient has very high CRP, so there's acute inflammation. The ANA is elevated and speckled, but oftentimes the ANA being like slightly elevated, we're always kind of like, oh, is it, how positive is it? So this is kind of like in that area where, it could be positive or really looking at 1 to 640, higher than that, would be kind of more of a slam dunk. Everything else being negative, like your ENA being negative really kind of tells you, hey, maybe it's like not really going that direction. So yeah, so now I'm thinking, with this, we can also look at the IG classes, right? So thinking about IgA, we would have a nephrology consult by now. Has the creatinine gotten any better or not?
So over the next 2 days, the creatinine actually was acutely worsening.
Okay.
A Foley was placed in order to track strict I's and O's, and the patient was very oliguric.
Okay, so getting worse and worse. And so as we track that BNP, whether or not that patient is going to need acute dialysis, is going to be in the background. One of the things I would specifically ask our nephrologist is whether or not a biopsy would be helpful to kind of figure out what's going on. And then the other kind of thing I would be thinking about is any of the post-infectious kind of syndromes. So did we get blood cultures?
Yep. So we have an infectious eval, and you've mentioned a number of these things. And so this infectious evaluation was done in the first 24 hours as well.
Okay. Not a lot of stuff. And then IgG classes.
And they were normal. Yeah,
those were normal.
They were normal.
Okay. So.
And I will ask, before I show you the immunologic labs, if in this case, and this was slightly different in this case, but I think, and you've already touched on this, how does your thinking evolve? We've talked about the ANCA vasculitis, and the ANCA labs were negative. If this patient were to have shortness of breath or any infiltrates on lung imaging, how would that change kind of the next steps as we're waiting for our wonderful renal colleagues? If it would change your management at all involving the lungs.
I think you could just send out those labs, right? So the anti-glomerular basement membrane antibody. But honestly, if like the ANCA is negative, it's already so rare. Having a rare version of like C ANCA vasculitis, not having an ANCA,
yeah,
it's kind of I would say, hey, we've hit a dead end. Let's back up and let's try to see if we can find if we've missed something else.
Yeah, so I love it. So at this point, I mean, you're managing multiple things, right? We've talked a number of times about the overall workup for what is looking like potentially a GN, along with working up and talking about potential infection that's happening concurrently with this fever and thinking about getting our subspecialty colleagues on board. I'll provide you these immunology labs as well.
Is that high?
That is high.
Is it very high?
So, so it is positive. I think the normal range is less than 0.8 or 0.9. So it's mildly elevated, but I will also say that in the ensuing 2 days after this, it does go up further.
It goes up further.
Yes, this was the first time it was obtained.
Okay. Okay, so with the elevated free light chains, one of the things that I kind of think about for these is that in an acute infection, everything should go up, right? Because you should have more. And the idea behind having like an increased ratio is that you're making, a specific one, right? So trying to think of, is there something going on that's causing there to be more? With the IgM kappa paraprotein spike, is that from an acute infection, or is that, are they just making tons of IgM?
Yeah.
So one of the things you could think about is like, also thinking about bone marrow, whether or not it's coming from there.
Yeah. And if I may, I would love to also ask Dr. Chang, or one of our nephrologists, just how do you interpret, because this is something I struggle with all the time, how do you interpret the kappa to lambda ratio in the setting of renal injury in particular? Because I know it does change.
Word? Okay. Tony, you're doing a great job. This is pretty mean for them to give you this case. So light chains are going to be cleared usually and metabolized in the kidney. So when you have any kind of decrease in clearance, especially kappa, is going to go up. It is very typical for us to see kappa lambdas up to 4, and it's just because of poor clearance. When you start to get beyond that, we start to worry a little bit more that it's something else.
Thank you.
So
All
I
right.
guess the other thing that you could think about is, if it's greater than 4 and something else, are those depositing somewhere within the kidney?
Yeah.
And then it getting higher, like you're going to tell me, is that what's going on?
So what would you like to do next? I think we've covered a number of these things. And so at this point in your workup, what are you thinking about needing or wanting?
I think having nephrology's permission to biopsy would give us a lot of information. And I think it would be looking for specifically any of those antibodies that might turn positive.
Yeah. All right. So we'll obtain a renal biopsy, and I'm going to pass it to our wonderful pathology colleagues to go through those slides.
Can y'all hear me okay? Awesome. All right, so for any medical kidney biopsy, we evaluate it by light, immunofluorescence, and electron microscopy. So we'll go through all of those. This one was pretty striking. So, so this is a core. Can you all see my cursor? Oh, I think it went away. All right, cool. So this is a H&E image of the kidney biopsy. And when evaluating kidneys, I like to break it into 3 different components: the glomeruli, the tubular interstitium, as well as the vasculature. So in this case, this is a glomeruli, this is a glomerulus, but they're quite injured. So normally one would expect to see, a delicate tuft with small capillaries and then a surrounding Bowman's capsule. But in this case, both of these glomeruli are very injured. You'd have to believe me. I'll show you in a few special stains shortly that there is a residual glomerular tuft, but it's pretty much effaced by a cellular crescent. And these are multinucleated giant cells, suggesting that the Bowman's capsule has ruptured. And then this debris over here is a bunch of like fibro-inflammatory necrotic debris. So a pretty substantial glomerular process. The tubular interstitium, there is an acute inflammatory infiltrate, probably secondary to this process, composed of neutrophils and eosinophils. And I didn't really take any images of the vasculature, but other than having a little bit of arteriolosclerosis, there was no inflammation there. So one of the special stains we use is a trichrome. Usually it's used for evaluating for fibrosis, which would be a dark blue color. But in this instance, it can highlight a few important things for us. One is you'll notice these like dark red areas. So these are proximal tubules that are full of red blood cell casts. And then this kind of lighter red stringy stuff is fibrin from like fibrinoid necrosis. Lastly, silver stain. These are really useful for highlighting basement membrane. And so here you can actually see the remaining glomerular tufts that are present in these two glomeruli. This one is like fully necrosed. And this is the Bowman capsule basement membrane, which has been basically ruptured. And then there's a cellular crescent kind of spilling out into the tubular interstitium. So pretty striking process. So we have, this is pretty much seen in all of the glomeruli. So we have a diffuse crescentic glomerulonephritis. And so when we think of that, there's kind of another three main bins. It can be immune complex mediated. It can be when we would see immune complexes on immunofluorescence and electron microscopy. You could have a anti-GBM based disease where you get linear deposition of antibodies along the basement membranes, or you could have a posse immune process. Those are the ANCAs, though we would, again, probably see positive serology, or we would see vasculitis, which we didn't in this case. So next up, we'll show the immunofluorescence, which kind of gives it away. So this is a picture of like a medullary array of the tubules. And you can see linear staining for IgG along the tubular basement membranes. And then in some of the glomeruli, there's a very nice linear staining along the glomerular basement membranes. So really thinking about a anti-GBM based disease. We'll round it off with the electron microscopy to make sure there's nothing else going on. And I know electron microscopy can be a little bit intimidating, so I have this cartoon to the right here. So just as a reminder, glomeruli, you have the endothelial cells, basement membrane, the podocyte surrounding them, and then the capsule. So over here on the left, this is a basement membrane. It's thin. There's no big globular, dark, dense deposits. This is an endothelial cell. This is a podocyte. So normally they have a nice they kind of form this slit diaphragm along the basement membrane as part of the filtration apparatus, but it's basically kind of smushed along onto the basement membrane. We call that diffuse podocyte flip process effacement, which is a buzzword for minimal change disease, but we can see it. It's not specific at all. We can see it pretty much in any case of glomerular injury. And just here's another like endothelial loop. I wanted to point out here that there is some cellular swelling. So these cells are very injured. And just to round it off, I just included this for fun. This is an example of what a cellular crescent would look like on EM. So up here is a capillary loop with an endothelial cell. These are red blood cells. All this stringy stuff is fibrin. And then here's the crescent along the outside. So again, to round it all off, we have a diffuse crescentic glomerulonephritis with linear IgG C3 deposits by staining by immunofluorescence with no electron deposits on EM. So all consistent with Goodpasture's disease.
Any other additional thoughts?
Yeah.
Yeah.
So it's probably progressive, so which would explain why she had very early acute symptoms that progressed so quickly. So
Yeah. So to take us through the rest of the hospital course, very interesting case. So this patient presented with their creatinine in the mid threes, as you saw. Within 2 days, it was well over 6. At that time, the hyponatremia, the metabolic acidosis, the volume overload led to pretty early initiation of dialysis, despite pretty rapid treatment and recognition. So she actually started receiving empiric treatment for an RPGN because this was recognized so quickly. And then ultimately, the patient was discharged and was still on dialysis and continues on dialysis at present. Interestingly about this monoclonal gammopathy, the IgM kappa, her cold agglutinin was testing positive. However, she's never had clinical symptoms. And it sounds like the temperature at which those were acting was too low for the patient to have clinical symptoms. However, it did interfere when they were trying to do therapeutic plasma exchange. It was clotting off the machine and impacting that machine as well as the dialysis machine, which presented quite a challenge as they were trying to do both the dialysis and the empiric treatment. And so she's still following with hematology as well. a couple of teaching points on anti-GBM disease. So very, very interesting disease, very heterogeneous in presentation, meaning that a majority of patients, about 90% of patients, do have kidney involvement. Only 20 to 60% also have pulmonary involvement. And it's thought, and kind of odd in this case, that it seems that she did have some sort of acute infection, that maybe the people who have pulmonary involvement have a concomitant infection that is involving the lungs, leading to exposure of that collagen that's usually not exposed as it remains under the glomerular basement membrane. And then one of the other things I learned through this case is that, you know, these patients, the GBM antibodies in particular are to the alpha-3 chain of the type 4 collagen, which is predominantly expressed in the lungs and kidneys and expressed very minimally in other tissues or completely absent, because glomerular basement membranes are throughout, you know, the body. And then in terms of treatment, so when patients present, their creatinine and the anti-GBM antibodies directly correlate with one another. And so this patient's anti-GBM antibodies were greater than 8 by about the 4th day, and the titer doesn't go higher than that. So for about 5 days, it just showed greater than 8, greater than 8, greater than 8. And you treat them until you can get them to be completely suppressed. Granted, most patients who are on dialysis at some point with anti-GBM disease tend to end up needing dialysis long-term, and there is some debate as to whether or not you need to treat them any further after that if they've already lost their renal function, if they don't have pulmonary manifestations as well. Any other thoughts from our nephrology colleagues?
Given that this is a process, her case, striking, I think that she didn't have any depositions on the basement membrane. So what is she a potential candidate down the road for renal transplant?
Now working. Oh, so there was immune deposition, right, on the IF, right? We did see the IgG along basement membrane. Yeah. Yeah. So that's pretty characteristic for the anti-GBM disease. I don't remember how old this patient was. Anti-GBM is not a disease that recurs frequently. So a lot of these patients would be great candidates for transplant. I don't remember how old this patient is or if she had other.
68.
Yeah. So possible.
And I think that is actually where they're at right now. It looks like there's discussions because, again, otherwise very healthy. And I think the Sjogren's was a bit of a red herring, again, not a pathologic diagnosis. And there was, and correct me if I'm wrong, you know, there was some concern for MGRS as well, just knowing that they had the monoclonal protein. But the diagnosis on path was so convincing. And obviously the anti-GBM antibodies, having seen that tracked so closely in this patient presenting with such a rapidly progressive disease, is all consistent with this process. All right.